Advanced Customer Life Support. Mid-Georgia Ambulance began serving the citizens of Georgia over 35 years ago. Founded in Macon, MGA now provides service in numerous counties across the state. Employing over 340 people, MGA provides emergency medical transport services, non-emergent transport services, neonatal transport, special event coverage, and community CPR training. MGA's mission statement and corporate policies are to be and be recognized as the best ambulance service in the state. Work for the growth of our associates in all areas of their life, both on and off the job. Improve the quality of life in every community in which we operate. And carry on all business matters and relationships according to the highest of ethical and moral standards as taught by Jesus Christ. Maintain as the highest concern the delivery of quality patient care at all levels of operations. Demand of its associates the highest level of professionalism at all times. Maintain quality patient care by maintaining financial viability. Abide by all laws and rules and regulations as set forth by the United States of America, the Federal Communications Commission, the State of Georgia, the Department of Public Health, the regional EMS councils of Georgia, and all local governments or agencies concerned with emergency medical services. These can be found and referred to at any time in the MGA Employee Handbook. Our goal is to communicate and renew the notion of great customer service to new and current MGA employees. You may wonder, why do I need to know this? Management receives complaints, large and small, from unhappy customers. 90 to 95% of the time, it stems from the topics that we will be discussing today. Poor attitude and body language can weigh heavier than most minor medical mistakes. There is a customer service principle called the Net Promoter Score. It boils down to this. When a customer has a good experience, they tell about 5 people. When a customer has a bad experience, they tell 15 people. Even if we're the only game in town, there's always a choice. So who are our customers? They can range from those we care for and their families to those we work with, and can include the public, which is watching even when we do not realize. Rule of thumb: anyone we come in contact with while in uniform is a customer. Efren Turbin sums it up well with his definition of customer service. Customer service is a series of activities designed to enhance the level of customer satisfaction. That is, the feeling that a product or service has met the customer's expectation. What is customer service to you? Some have a hard time defining customer service, but can tell you when they have not received it or a poor attempt at it. Let's take a moment to look at a few issues that contribute to poor customer service. The lost art of please, thank you, and I'm sorry. In the public service sector, we must remember that we serve the public. Being polite can help diffuse some tense situations. Remember, the hardest of truths can sometimes be taken easier with sincere emotion and a kind word. We all have bad days, but as professionals, we should not let our bad day influence how we treat others. Sometimes it is good to gain perspective on things. You may think that your personal issues make today a bad day, but the patient with an acute myocardial infarction has got you beat. Emotional leakage can cause one bad experience for our customer, which leaves them to think all medics are cold and uncaring. Apathy is defined as a state of indifference. When we are uncaring or indifferent to our customers, it may exacerbate their situation or condition. We should always exhibit some level of concern when dealing with our customers. If we do not care, then they may not care to call us again. Let's take a moment to discuss ego. A pinch of ego is needed in our profession. This can help us get past some difficult situations that we encounter. Too much ego can blind us from the reality of the situation, and important details can slip through the cracks. Ego can also prevent us from bettering ourselves because we think we know it all. How do we provide the best customer service possible? Let's go over a few things that can greatly improve our customer service. The public has the perception that we are simply ambulance drivers. Unfortunately, there are some in our profession that reinforce this with poor attitudes and being improperly prepared for each call. The ambulance driver will walk into a patient's house with nothing in hand and ask, "How are you doing today?" This can be disconcerting to a tripoding CHF patient with only a handful of breaths left in them. The medic, a true professional, exits the ambulance and moves towards the patient with purpose, carrying the necessary tools of trade in hand. That could be a jump bag, stretcher, and a cardiac monitor. The first 10 seconds can say a lot about you and our company. Be aware that the patient will remember what you say, how you say it, what they see, your body language, your appearance. Are you sloppy looking or pressed and professional? Your inaction or action. The Phoenix, Arizona Fire Department has a very extensive code of conduct which implores and holds their employees to their jobs as public servants. They will change tires on the side of the road and other acts that do not fall under their normal job titles, making going above and beyond the norm. The following is a brief excerpt from their code of conduct. We have become the agency of last resort for the poor, the homeless, the destitute, the mentally, emotionally, and physically challenged, the chronically ill, the indigent, the incarcerated, and the immigrant. This is the portion we should all pay close attention to. Interpersonal awareness and sensitivity is our responsibility. Indifference or lack of empathy is a professional weakness. The public does not need one of our members to be having a bad day. When they call us for help, they are already having one of their own. Perception is reality. If we act like professionals, then professionals we are. Remember the old saying, if it looks like a duck, quacks like a duck, it's probably a duck? If one or two medics act and appear unprofessional, then we all suffer that label. Here are a few ways to further the public's perception of us as professionals. Showing genuine concern and empathy. Doing a good job for the sake of a job well done. Acting with confidence as a direct extension of our medical director. These confident actions should leave no question in our patient's mind that we are there to help them. We should operate as if the medical director were there with us on every call. We have the backing of our medical director to treat patients under our standing orders. If we do not readily know, then we have the resources to call medical control and seek guidance. Here are some things we can continue to do to provide the best quality of care. We bring the hospital to the patient. We should instill confidence in the patient that we have all of the necessary tools to stabilize their condition within our ambulance. We can boast that we have a high level of training and know how to use it. We as professionals should always constantly seek to improve ourselves. We have multiple opportunities to learn within our company and our state. We need to take the initiative to be informed and seek training, even when it is not required of us. If we improve ourselves, we can directly improve our profession. Okay, let's pull it all together here. What can you do? Be professional. Move with purpose. Be mindful of what you say and how you act around customers. Everyone is a potential customer and should be treated accordingly. Provide the best quality of care. Know that you have all the tools you need to provide quality care. Do not default to the "I'm just a ride to the hospital" mentality. Put your best effort forward for each call. Constantly seek to improve yourself and your profession. Know your weaknesses and seek to strengthen them. Do not be afraid to ask for assistance. Have the initiative to seek out training, even when it is not mandatory. So in summary, the age-old rules of customer service are: rule number 1, the customer is always right. Rule number 2, if the customer is ever wrong, reread rule number 1. Remember, you are representing yourself, your company, and your profession. Make your lasting impression a positive one. Driving and vehicle safety. Everyone goes home safe. Our objectives are to improve the awareness of our associates by outlining prominent safety issues for our crews and patients, to review the top causes of crashes and collisions in the ambulance industry, and to review the proper technique for mitigating traffic hazards when operating the ambulance. Driver safety awareness. Our number one priority is to make sure that the patient, public, and our crews go home safe at the end of the shift. We are the only medical profession that transports patients on a regular basis. The ambulance is the one piece of equipment that we use on every call. Every time we turn the wheel, we are assuming a risk to the communities we serve. We have their trust that we will keep everyone safe when we operate the ambulance. As EMS providers, we should be role models of proper driving techniques. We have to change our attitudes towards driving safety. The consequences can be fatal if we maintain the attitude that we own the road and everyone better get out of our way. We must keep in mind that when we are driving, we are wielding 12,000 plus pounds of ambulance. It should be noted that both crew members in the cab are responsible for the safe operation of the vehicle at all times. EMS providers are 7 times more likely to miss work due to injury than other professions. Non-fatal injury rates are 5 times that of other healthcare workers. The fatality rate is 2.5 times greater than the national average. As for transportation-related fatalities per 100,000 workers, the national average is 2.0. The rate for firefighters, 5.7. Police, 6.1. EMS is an unfathomable 9.6. We have some work to do. One way to do this is to be familiar with the most common issues that cause injury or illness in EMS, often referred to as the Super 17 safety violations. Unsafe driving, backing without a spotter, failure to come to a complete stop at a controlled intersection. That includes the use of a 3-rock stop. Exceeding the posted speed limit by more than 10 miles per hour when driving emergency. Remember, speed does not save lives. Failure to comply with the driving policy, and this can have the death penalty enforced on it. Failure to keep portable equipment stowed and secured properly when possible to do so. It should be noted that items such as spare batteries, books, etc. can become projectiles. It's also a good idea to make sure that the sharps containers are secured in a fashion so that in the case of a rollover, the contents don't become missiles. Failure to comply with the OSHA bloodborne pathogens policy. Failure to comply with the OSHA airborne pathogens policy. Failure to wear a safety vest when in or around traffic. Smoking in any vehicle or building at Mid-Georgia. Failure to wear seat belts. Failure to properly secure patients or any other occupants in the ambulance. This is similar to the failure to stow. Failure to properly secure the patient to the stretcher to include shoulder straps. And these are to be used on all patients. Failure to secure the patient to the backboard with all straps. Failure to use proper lifting techniques. Remember, lift with the knees, not the back. Failure to stand by off scene for all scenes that are potentially dangerous. And failure to comply with the procedure for endotracheal intubation verification. We constantly train to maintain and improve our clinical skills. But what if I told you that driving is a clinical skill? The patient's condition relies on your treatments and clinical skill, but also getting them to higher level treatment at the hospital is extremely important. No matter how clinically gifted you are, but are not driving safely, you have failed the people who trust you to keep them safe. We must have the mindset that driving is a clinical and life-saving skill. To prevent mechanical failures that can cause a collision, regular vehicle maintenance is necessary. Vehicle maintenance is not solely the mechanic's responsibility. Fleet Operations performs regular maintenance of the vehicles, but if a problem arises between services, they will not know unless notified. Crews performing pre-operational inspections of the ambulance are extremely important. Sounds or motions that appear to be out of the ordinary should be reported immediately to Fleet Ops. Prior to entering and operating the vehicle, we must make sure that we're not putting anyone at risk of injury. Checking the area immediately around the vehicle is referred to as the circle of safety. This practice was put in place by the transportation and utility sector to reduce damages and injuries from preventable hazards. It is a simple walk around the vehicle before entering to identify any potential hazards. We should all be aware of our surroundings when on duty. This awareness level helps us identify hazards to our crews and to our patients. We can use this awareness when operating our ambulances. The 20 to 30 seconds it takes to clear the vehicle can save the delay it would take to get another unit to your patient and to fill out an incident report. Wheel wells are easy places for children to play and hide. The circle of safety helps prevent any of these tragic accidents. Seatbelts are proven to decrease significant injury from a collision. We see firsthand the injuries that occur when they are not used as indicated. As role models for proper driving and vehicle safety, we must always use seatbelts while operating the ambulance. Also while traveling in the patient compartment, unless patient care is being performed. The easiest way to prevent crashes and collisions is to make sure that the seats and mirrors are properly adjusted to reduce blind spots while driving. Adjust the side mirrors so that you can clearly see a portion of the rear of the ambulance to use as a reference point for objects and other vehicles. Making these adjustments prior to moving the vehicle can help prevent collisions. Even when properly adjusted, the mirrors will not catch everything. Leaning forward in your seat to change the perspective can increase your visual field on the side of the ambulance. Respecting the risks and knowing how to reduce them prior to moving the ambulance can improve the care we provide our patients in the communities that we serve. Top reasons for collisions. There are a handful of things that distract us in the cab of the ambulance alone, versus all of the actions happening outside of the vehicle. We must always pay attention to our surroundings and anticipate what others may do around us. Distracted driving has been proven to be more deadly than drunk driving. Tinkering with your smartphone or radio, jamming out to the music, eating while driving, and not staying focused on the road ahead can result in a deadly crash. Studies have shown that even with hands-free devices, you can be distracted and it can delay your reactions to road conditions. In EMS, we know we're not promised to sleep or eat when the rest of the world does. We have to get it while we can without putting ourselves in harm's way. Those that eat and drive are 1.6 times more likely to be involved in a collision. A solution to this issue is for the crew to take turns driving while the other one eats. This may mean that your food gets a little cold, but you will be safer for it. As our use of technology increases, so does the potential for crashes from being distracted. Radios, phones, GPS modules, and operating controls for lights and sirens can all be distracting hazards. Virginia Tech researchers suggest that reaching for one of these devices makes you 8.8 times more likely to have a collision. Drivers should refrain from performing radio communications while the vehicle is in motion. It is recommended that the crew member in the passenger seat operate the radio and the lights and sirens when the vehicle is in motion. If the driver is alone in the cab, other than lights and sirens, the required electronics should only be used when the vehicle is not in motion. As a driver, your performance relies on several capabilities: visual, cognitive, and mechanical. You must be able to visualize all hazards around you. You must then be able to use the information your brain gathers to send physical commands to your body, like turn the wheel or hit the brake. Finally, if all goes well, your body must have no physical hindrances to delay reactions to hazards. Whether moving or sitting still in traffic, we must always leave enough room to maneuver safely around other vehicles or hazards. If we are sitting still in traffic, we always want to move forward towards our destination. This can leave very little room to navigate around the vehicle in front of you if needed. The driver must always leave enough space between the ambulance and the vehicle in front to allow the driver to clearly see the vehicle's back tires touching the ground. As we start moving in traffic, we must keep the cushion to help avoid a sudden stop and rear-end collision with the vehicle in front of us. There are some individuals out there that make a great living being the victim of a rear-end collision. Moving at highway speeds, the driver of the ambulance should use the 4-second rule. Leave at least 4 seconds of distance between the ambulance and the vehicle in front. For example, the car in front of you passes a pole. If you cannot count 4 seconds before you get to the pole, you are following too close. Backing without a spotter is strictly prohibited. Use of a spotter is mandatory unless your partner is attending to the patient in the back of the ambulance. Remembering your circle of safety before getting into the vehicle can help identify any hazards that a lack of a spotter can produce. The average driver operates reverse at least 1 mile per year. Consequently, 25% of all commercial vehicle collisions can be attributed to backing. Backing an emergency vehicle is very hazardous. There are many accidents and injuries which result from improper backing practices. Emergency vehicles of all types are especially hazardous because many have blind spots interfering with the driver's ability to see the hazards. To reduce the risk of accident and injury, emergency service organizations should have standard operating and training guidelines which mirror the following recommended practices. If you can avoid backing, don't do it. Never be in a hurry when backing. If there's no spotter available, reconsider backing up. Is it really necessary? Make a reasonable attempt to get someone to act as a spotter. If a spotter cannot be obtained, get out of the unit and walk around, completing a circle of safety, and survey the backing area. Before proceeding to back the unit, be sure to also check overhead clearance. When backing and your partner is in the back of the ambulance, have them sit on the bench seat at the back doors to look out the back windows for obstacles if possible. Give a final warning of 2 horn blasts just prior to backing. The driver responsibilities are to bring the unit to a complete stop. Roll the window down completely. Make visual and verbal contact with the spotter. If you cannot see or hear the spotter, do not back up. Driver and spotter must establish and continue eye contact in the left rear view mirror at all times. Drivers must have a thorough knowledge of spotter hand signals. The spotter hand signals to the driver indicating it is safe to begin backing, and the driver gives a 2-blast warning on the horn just prior to backing. The spotter responsibilities include conducting a circle of safety and survey the backing area and all other sides of the vehicle, checking for hazards. Before proceeding to back the unit, be sure to also check overhead clearance. Communicate any observed hazards to the driver. Place yourself 8 to 10 feet to the rear of the unit. Establish visual and verbal contact with the driver and continue eye-to-eye contact in the left rear view mirror at all times. Be familiar with hand signals before allowing backing maneuvers to begin. And stop the driver if any hazards are observed or if you are uncertain of the direction that the driver is maneuvering. To move straight back or forward, wave your hands forward and backward with your palms facing the direction of travel that you want them to go. To turn, use one arm pointing in the direction that you want them to go and use the other arm to wave them in that direction. Distance to stopping point. Hold your arms in the air and slowly close them as the gap closes between you and the other vehicle or obstacle. Stop or emergency stop. Cross your arms with fists closed over your head to show the driver that they need to stop. For an emergency stop, wave your arms wildly to get their attention and tell them to stop. Operating the ambulance with lights and sirens, or running hot, can be one of the more dangerous aspects of our profession. Research shows that responding with lights and sirens has not shown a significant difference in whether or not the patient survives. The National Highway Traffic and Safety Administration states that about 70% of ambulance collisions occur when the ambulance is running hot. Exceeding the speed limit saves only 43.5 seconds on average. But speeding exponentially increases the risk of a collision. Our responsibility as patient advocates is to do what is best for the patient. Use of lights and sirens is not always clinically significant, and we should evaluate the risk versus benefit. Studies have shown that running hot can in fact do more harm than good. It can induce stress in patients with acute coronary syndromes and stroke, which increases cardiac workload and increases metabolism, causing more damage to the heart or brain. Cardiac arrest patients are less likely to benefit from lights and sirens due to the inability to provide continuous quality compressions. This can be hard to do whilst being thrown around the back of a speeding ambulance. Exceeding the speed limit is dangerous. It reduces your reaction time to unknown hazards and reduces the control you have over the ambulance. The speed limit should only be exceeded if the patient is in imminent danger of death. The crew should then only go 10 miles per hour over the posted speed limit, and only if road conditions are perfect. Some instances are acceptable to travel over the speed limit. There are some patients that regardless of speed will have a bad outcome. Speeding endangers the lives of the public, the patient, and the crew. Remember, speed does not save lives. Well-trained medics do. As EMS providers, we should have a good understanding of the forces that act against us and the vehicle when in motion. Newton's first law of motion states an object in motion stays in motion until acted upon by outside forces. It's not the fall, it's the sudden stop at the end. Career-altering injuries can occur from being thrown around the back of the ambulance. This is Newton's law of inertia at work. Centrifugal force is often felt on sharp or sudden curves, pulling objects away from the direction of the ambulance. Traction is the friction between the vehicle and the driving surface. Increased weight and speed increases the stopping distance. The faster the ambulance goes, the longer it will take to stop. When the road is dirt, gravel, or just wet, traction is decreased, so stopping distance is increased. Being aware of the forces that act against us while driving can help us appreciate how to safely operate the ambulance. So remember, do not text or use your cell phone while driving. Refrain from following too closely. Always back with a spotter. Use approved hand signals for optimum communication. Speed does not save lives. Well-trained professionals do. And remember the forces working against the driver and technician in the back. How to properly mitigate traffic. 5 keys to reduce collisions. Do not focus solely on the vehicle in front of you. Keep your focus farther down the road so that you are aware of issues 15 to 20 seconds in advance. Look out for all hazards, including other drivers, pedestrians, vehicle doors, animals, and etc. Use your peripheral vision. Many drivers have a bad habit of staring ahead when driving and are oblivious to what's around them. Make sure you can safely get out of a potentially hazardous traffic situation. Leave enough space around the ambulance for you to pull over to another lane safely. Make sure that other drivers and pedestrians know what your intentions are. We are in a large vehicle that is hard to miss, but when we fail to use our headlights, turning signals, or hazard lights, we can cause avoidable collisions. We discussed that adjusting your seat and mirrors prior to operating the vehicle can reduce blind spots. It can also improve your vision and maintain your cushion of safety. The cushion of safety is the area around the ambulance that you should try to keep free of other vehicles, pedestrians, and potential hazards. Maintaining this cushion can improve your reaction time to unforeseen hazards. Know the size of your vehicle. The average measurements of our ambulances are 9 to 10 feet tall, 8 to 9 feet wide, and 20 to 21 feet long. This will increase your awareness of the ambulance on the road. Of all the areas around you, you have the most control of what is directly in front of you. This means keeping an adequate following distance, signaling in plenty of time for a turn, and covering the brake when a potential hazard presents itself. An easy way to anticipate these hazards is to look or scan ahead to identify issues before they affect your route. Looking ahead, behind, and to the sides can help spot vehicles moving around you, especially in a tailgating position. When approaching intersections, remove your foot from the accelerator and place it over the brake pedal. This will vastly improve your reaction time if a vehicle or pedestrian moves into your path. All providers should have a basic knowledge of their service area. You should be familiar with potential hazards to include poor road conditions, narrow bridges, ramps, sharp curves, and other hazards. Most ambulance crashes in rural areas involve fixed objects such as trees, ditches, signposts, and other hazards. When the weather is dry and sunny, the roads are fairly easy to navigate. Anytime the weather changes, the ambulance can react differently to road surface. Maintaining your cushion of safety, looking ahead, covering the brake, and being familiar with the road conditions of your service area will help prevent crashes and collisions. There is an endless list of situations you will encounter while driving the ambulance. We will be discussing the top issues for most drivers. These issues go for both patient-loaded and non-patient-loaded driving. Care should be taken whenever you're loaded or not. Know that when driving without a patient, both medics are up front and seat belted in. Sharp turns are not noticed, even at speeds slower than the posted speed limit. When patient-loaded, the patient and the medic in the back can feel the changes in the road 3 to 4 more times than the driver. So that minor bump or slight turn can cause the patient or medic to be slung around the back without the driver ever being aware. Properly clearing intersections can be a challenge in an emergency response. Care must be taken not to endanger the public when responding to a call for help. When approaching the intersection, the ambulance must have all the proper sirens and lights active. The ambulance must come to a complete 3-rock stop. After the complete stop, use your horn and sirens to clear the intersection. If other drivers do not respond and keep moving, you must wait for them to pass. When you are clear, proceed slowly across each lane until you have passed through the entire intersection. The best advice is, when in doubt of what others will do, assume they will not stop. We discussed the use of turn signals. It is important to signal far enough ahead to make sure that the drivers and pedestrians around you understand that you are turning. Always be on the lookout for pedestrians when making turns. A full stop is always good practice before a turn and can allow you to view the road ahead for any hazards. When making left turns, always use the far left turning lane. This will allow full control of your turning lane and for you to maintain the left lane for emergency driving. When driving in congested areas, it is important for you to leave enough space, 10 to 12 feet in front of your vehicle, to allow you to pull around the vehicle in front of you. This will also help prevent that vehicle from stopping short and contributing to a rear-end collision. Your stopping distance is increased when traveling at highway or interstate speeds. Leaving distance between you and the vehicle in front will reduce the chance of a rear-end collision. Remember the 4-second rule. Keeping a good cushion of safety will also help compensate for tailgaters. Tailgaters are notorious for hiding in the ambulance's blind spot. Constantly checking the mirrors and roadway will help you be more aware of these drivers. If you spot one that is tailgating, do not brake check. Slowly decelerate and let the driver pass. Their impatience should not be the catalyst for a collision. An issue when driving emergency in congested areas is knowing when is it acceptable to enter the oncoming lane. When all lanes in your direction of traffic are stopped, check the oncoming lanes to ensure it is safe to pass. It is then acceptable to cross into that lane of traffic to clear the stopped cars. As soon as it is safely possible, re-enter the proper lanes of traffic. Remember the 5 keys to reduce collisions. Keep in mind the size of your ambulance and the space around it. Remember to cover the brake. Knowing the driving area or use extreme caution on unknown roads. Use a 3-rock stop when clearing an intersection. Use all of your available traffic signals when turning. Do not follow too closely and beware of tailgaters. Use caution when maneuvering through oncoming lanes of traffic. So in conclusion, reducing the risk of collisions is every provider's responsibility. We are trusted to provide safe and reliable care to the communities we serve. Following these guidelines will ensure that you are providing the best and safest experience for the patient. Always remember to drive safely so everyone can go home safe at the end of the shift. Hello. Today we will be getting a refresher on the EPCR and going over some documentation practices. The goal of this training is to go through the major sections of the EPCR and refresh field associates of what is expected and required of their documentation. So a call is born. A citizen or medical facility calls into CMED. Our dispatchers use a set of questions, or ProQA, to make sure the proper resources are sent. Once the correct unit is assigned and goes en route, a call is generated in the EPCR server. The EPCR is routed to the crew based on the truck number and crew members signed in on the EPCR tablet. After the crew makes patient contact, they open the EPCR and fill in the necessary documentation. This provides a durable legal record of the patient encounter and is used for medical, quality, and billing purposes. When the crew is completed with their necessary documentation, all crew members review and sign the call. After crew signatures are gathered, the call is signed off using the crew-specific passcode. The call is ready to be sent to the server for processing by QA and billing. Billing will verify the information and signatures on the call, then place it in a specific category based on the level of care and treatment provided. If all the correct information is present, the call can be billed to the patient's insurance company. The sooner we get all of the information verified and sent to the insurance companies, the better our chances of receiving full reimbursement for the services we provide. If all of the information or signatures are not present, then the call is audited through the QA process and returned to the crews for correction. We will discuss this further in the presentation. There are times when we randomly audit calls to ensure that we're providing the most complete and accurate information on our EPCRs as possible. With over a full year of EPCR data, we are seeing great strides in our documentation practices and also areas that we can always improve upon. Specifically speaking of the EPCR tablets and their connectivity, please make sure to fully reset your EPCR tablet at the beginning of each shift. This will ensure that the machine is refreshed and ready to go. When not in use, the EPCR tablets need to remain connected to their charging cord. Make sure that the tablet is connected to a work location and to your correct truck's Wi-Fi. If you are not connected correctly, it can cause delays in receiving your calls and could lead to lost or corrupted information. If possible, this needs to be verified prior to shift start and resolved before the crew leaves the station or runs a call. If you experience any extended loss of connectivity, please make sure your direct supervisor is made aware. If they are unable to resolve the issue, please put in an ePro IT incident report to ensure we track and repair any issues as soon as possible. If there are calls outstanding that cannot be saved to the server, the crew's immediate supervisor needs to contact our mobile IT department. Now that we have ensured that the tablet is connected properly, open the ePCR program. The login screen will ask for you to enter your name and passkey. Please make sure that you have a globe at the bottom right-hand side of the screen showing a green plus sign. If you are showing a blue exclamation mark, then you are logged on to another tablet or the tablet is still connecting to the server. Depending on connectivity, it could take a few minutes for the tablet to connect to the server. If you have a red X, then the tablet is not connected to the server or the internet. On the main screen, select the Current Crew button to set up the crew information for your shift. Make sure any crew or truck swaps are updated in this section. Click Add to set up the crew. A warning will come up stating that the person logged in must be a crew member on the crew information. Make sure that the shift start date, vehicle number, and crew members are correct. Select OK when complete. Make sure the information you entered is highlighted and select Set as Current to continue. If you are properly connected, the current call will generate in the bottom half or pending PCRs portion of the screen. Click on the call and a blue check mark will appear beside it. Click on Request PCR and the call will be moved to the top half or inbox portion of your screen. You can then open the call and fill in the appropriate information. If there are connection issues or a dispatch call does not show up on the bottom of the screen, do not panic. Click the New button at the top of the screen to generate a blank ePCR. This PCR will not have any dispatch, mileage, or times filled in. They will need to be manually entered. There will be times when connectivity is limited and you do not receive your dispatched ePCR. Do not panic. Start a new PCR. Once completed, save it to the server until the dispatch copy comes through. It will show as validation required. You can then pull up both calls, highlight them, and select Merge. Warning: merging is not able to be undone. If you merge the wrong calls together, your correct information may be lost. If the dispatch call does not come through, it could be that the crew information is not correct. Check dates and truck numbers. It could also be due to the call being reassigned and the original crew opened the call prior to patient contact. In either case, the call will be merged on the server side by management. If any issues still exist after merging, the crew will be made aware. The first screen is your trip screen, and that has dispatch information first. Make sure the information listed in the ePCR is correct. Let dispatch know if the pickup location is incorrect. We can update it on the ePCR side, but if dispatch is not aware, the information will remain incorrect. This causes issues in verifying information for billing, and documents or bills from MGA may be sent to the wrong location. Times will be filled in by the connection to dispatch and the information recorded by the Navigator tablet. Please check for accuracy. Mileage will be updated by dispatch based on the information from the Navigator tablet. Please check for accuracy before completing your call. The scene screen addresses any scene issues such as how the patient was found, location type, number of patients, and any scene delays. It is extremely important to confirm the patient's information with the patient. If you list the hospital as the patient's address, then that is where the bill is sent. This can delay the reimbursement process immensely. Phone numbers are extremely important. If we do not have a valid phone number, then we will be unable to verify important information with the patient. As a rule, list as much information about the patient as possible. Any responsible party information should be recorded on this screen. Insurance and employment status are documented on this screen. If any workman's comp information is present, fill in the information at the bottom. For insurance companies, click the Add button to add each insurance provider. Please include as much information as possible, and be sure to take pictures of the insurance cards listed if available. This screen is where the crew uses their assessment to document whether the patient meets medical necessity. Let's discuss a few of these topics further. Bed confined status is the inability to get up from bed without assistance, and the inability to ambulate, and the inability to sit in a chair, including a wheelchair. All three conditions must apply, not one, not two, but all three, and the narrative should support these findings. Clues to the patient's normal status can be a jerry chair being present versus a wheelchair, turn schedule, or other items in the room that would only be necessary for those that cannot move by themselves, such as a Hoyer lift. Posturally unstable. The patient cannot walk without assistance. This includes use of a cane, walker, or the crew holding the patient steady while walking. In the pictures below, the elderly female having two firemen assist her is someone who is posturally unstable. The female walking around a jogging track would be stable. Was sitting contraindicated? Did the patient have a decubitus ulcer or other reasons they could not sit in a wheelchair? Did the patient not have the balance or stability to sit upright without falling over? Remember, a jerry chair is not a wheelchair. It is designed to recline the patient in a semi-seated position. These are used in skilled nursing facilities and dialysis centers. The patient on the left is secured in a jerry chair with straps to keep him from falling over. The patient on the right is secured with straps in a wheelchair to keep her from falling over or falling forward. With the CERT CMS section, we need to avoid conflicting information with the narrative. This could be an example of documenting the patient was able to walk without assistance, but the CERT CMS question of bed confined was marked yes. Those are two conflicting pieces of information. The CERT CMS information should be based on the crew's assessment, not the physician certification statement. Remember to accurately document the patient's condition at the time of transport. Back to the EPCR. Chief complaints can be recorded on the Chief Complaints screen, and they can be selected from the list on the right. Please denote which complaint or complaints are primary and document the duration of these symptoms. List the cause of injury if applicable. If no injury, be sure to select none. Please list any and all past history on the patient. There is an other option to type in a condition if not listed on the right. Please list any and all medications for the patient. There is an other option to type in any medications that are not listed on the list to the right. Please list any allergies for the patient. Like said before, there is an other option to type in any allergies that are not listed on the right. No known drug allergies is available if no allergies are present. Please list the location and organ system of the chief complaint. A condition that affects the entire body will be listed as general or global. Document the primary symptom if applicable. List who the medical history was obtained from. For female patients, document if they are pregnant or not. For male patients, this field must be documented not applicable. On this screen, you can document the mechanism of injury. If no injury, document not applicable. This screen allows you to document a full head-to-toe assessment starting with the critical systems. The body survey is very detailed. If you are unable to find the specific issue on the list, use the Annotate feature to draw or write on the part of the body that is affected. Please use appropriate drawings and verbiage. Once completed, select Done. If your patient has an isolated complaint or no physical complaint, document what the issue is and then select Auto Mark. This feature will allow you to mark all of the undocumented fields as not assessed or within normal limits. Make sure to document any pre-existing issues such as amputations or contractures. On this screen, you can list any applicable impressions of the patient. On the trauma screen, you can document any trauma categories, and these are for that small percent of patients that actually meet a certain trauma category. This screen is for any contributing factors to an injury. If no injury present, select Not Applicable. For cardiac arrests, fill out as much information on this screen as possible. For the vital signs screen, click the Add button to put in sets of vitals. Remember, all transports require at least 2 sets of vital signs. This shows that the patient was monitored from point A to point B. When entering any interventions, there is a quick log for certain patient types. Select the Category button to see all the types available, such as cardiac arrest, chest pain, stroke. We have listed the common treatments for the various patient types. If you do not see the intervention you performed, select the Interventions button for a full list. Interventions are categorized on the list to the right. All interventions must be documented here, including CPR, oxygen, cardiac monitor, 12-lead EKG. Yes, cardiac monitor and 12-lead EKG are 2 separate interventions. Any extrication, ROSC, any IVs, IOs, any airway attempts, or any medications given. Remember, if you did not document it, then it did not happen. The Outcome screen allows you to put in various transport information, including response type, patient disposition, protocols used, how the patient was transported, and to where. Be sure to check for correct transport priority and check for the correct destination. These are extremely important in processing the call. The Time screen here is linked to the one in the Trips tab. Please review for accuracy. On the Signature screen, please note that the signature types are very close together. Make sure to double check you have selected the correct signature type before the patient or anyone else signs. A signature captured under the wrong signature type could be invalid. Let's discuss these signature types in detail. Signature type A is for the patient and no one else. Signature type B is for any responsible party, and this is when a patient is unable to sign for themselves. If they are not feeling like signing or would rather someone else sign, please remind them that without their signature and they were conscious and alert, then they will be billed directly and we are unable to bill their insurance if they do not sign. If they are unable to sign, please make sure that there is a reason unable to sign. This must be listed and supported in the narrative. Signature type C is for the crew. This is a very common one when the patient is unable to sign for themselves and there is no responsible party available. The crew member must sign their name, attesting that there was no one available to sign the EPCR on the patient's behalf. This is not accepting responsibility for their bill. This is simply the medic stating that at the time of transport, no one was available to sign for the patient, including themselves. We also need to list the reason unable to sign. This must be listed and supported in the narrative. A receiving facility signature must be obtained on all transports. A transport of a patient to their home must have a patient signature and a receiving facility signature. It is all right if the patient signs as the receiving facility if the destination is their residence. For skilled nursing facilities, please make sure you get an RN, LPN, CNA, or sitter to sign as a receiving facility. Refusal of treatment and transport must be obtained if a patient refuses all treatment and transport. It is not designed for patients that refuse part of your care and accept transport. If a patient refuses a treatment, clearly document it in the narrative and include your advice to the patient, encouraging them to accept the treatment. Now back to the EPCR. This screen allows for the crew to sign the call. Make sure the date is correct and the vehicle number is correct that's listed. The time summary allows you to look at the timestamps for transport along with any interventions and assessments performed. Please review for accuracy. The next section of the EPCR is the narrative. Let's take a few minutes to look over the D-chart method to help fill in all of the necessary information required in our narratives. This information should be gathered on any patient contact regardless of transport. Dispatch information. For example, Unit 572 responding to a respiratory distress. The next letter is C for complaint, along with the age and gender. For example, crew arrived to find a 57-year-old female with difficulty breathing. This includes how the patient was found. For discharges and pre-scheduled transports, please list why the patient was in the hospital. This information is extremely important. The next letter, H, is for history of present illness and pertinent past medical history. For example, patient states that the respiratory distress has become worse over the past hour. She has a history of asthma and hypertension. A in the mnemonic stands for complete assessment. For example, patient in mild respiratory distress. No accessory muscle use or cyanosis present. Lung sounds are clear in the lower lobes, with some wheezing in the upper lobes. No JVD or edema present. Head to toe otherwise unremarkable. Make sure to clearly document any distress presented by the patient. The R in the mnemonic stands for care and treatment by EMS. For example, crew assisted patient to stretcher, assessed vital signs, and loaded into the ambulance. Blood glucose level assessed and within normal limits. INT established in right hand with normal saline flush. Patient given 1 albuterol and 1 ipratropium bromide mixed updraft treatment, resulting in the relief of symptoms. Patient medically monitored during transport. This includes how the patient was moved to or was placed on the stretcher. Include any stair chair use. Please make sure that you note the patient was medically monitored during transport. This does not necessarily mean cardiac monitoring. It means that you monitored the patient's vitals from point A to point B. The T in the mnemonic is for transport or non-transport information. For example, transported patient to hospital ER per request. Advise staff of patient condition and upon arrival place patient in room 12 and assisted patient to ER stretcher. Report given to RN Doe. Patient able to sign for herself. No further changes during transport. Make sure to document if the patient could not sign for themselves and why. The E in the mnemonic stands for exceptions. If protocol treatments were contraindicated, document why. For example, your 52-year-old male was having chest pain and you did not give aspirin because he had already taken 324 milligrams prior to your arrival at the scene. If extended time on scene, document why. For example, your 36-year-old female patient is morbidly obese and is located in the back bedroom of a narrow hallway with clutter. Was medical control contacted for orders? Why and what was the reason? For example, your 13-year-old 45-kilogram male patient is experiencing persistent wheezing and you contact medical control for 1 gram of magnesium sulfate. Other exceptions. Did the patient refuse any treatment or transport? For example, you ended up transporting the patient, but they initially refused, delaying you on scene. The patient refused being placed on a long spine board, but agreed to a C-collar. Document any advice or cautions communicated to the patient if they refuse treatment or transport. Statements like, "You may suffer serious harm or death because you refuse this treatment," is appropriate to document in your narrative. So back to the EPCR narrative screen. The D-chart narrative can be listed out like this. I prefer it, it's cleaner. You remember each portion whenever you fill it out. Or can be written out in typical paragraph form. All the same information is there, it's just all pushed together and you could forget something, so it's your choice, the list or the paragraph form. The narrative screen has a spell check option. Please use it. It will not catch the wrong word being used, such as whale instead of while, but make sure both crew members review the narrative prior to completing the call for any mistakes or missing information. The EPCR tablet has front and rear facing cameras, great for taking pictures of documentation. Any paperwork should be photographed and attached to the call. This includes IDs, face sheets, insurance cards, physician certification statements, airway forms, and any other necessary medical paperwork. Select the camera utility, and then in a well-lit area, place the paper document on a flat surface and hold the tablet square above until it is fully visible on the screen. Carefully take a clear picture of the document. Using the Attach button in the EPCR, add the pictures from the tablet to the correct call. Pictures will be erased periodically for security purposes, so make sure that at the time of the call you attach the proper photos. All paperwork must be labeled with the run number at the top of the document and turned in at the end of the shift. Do not leave unattended paperwork in the ambulance. All calls that result in a transport to an ER must have a face sheet. On all Priority 5 calls, make sure a PCS is completed by the sending facility. If one cannot be obtained, please make sure you document why in the E part of your narrative. Remember, the PCS is the facility's assessment of the patient. Your assessment and CERT-CMS questions are completely based on what you and your partner observe of the patient. Complete call rules are different for each patient and transport type. If you continue to get a red X and cannot resolve the issue, please write down the error and put in an ePro IT incident report to ensure we track and repair any issues as soon as possible. As discussed at the beginning of the presentation, there are times when all of the necessary information or signatures are not collected. This poses a problem for billing, and correction of documentation errors or clarification of vague documentation must occur to seek proper reimbursement. Calls are identified by billing and placed in a special queue. Common issues for calls being returned are no reason listed in the signature language or narrative why the patient could not sign for themselves, conflict between the CERT CMS questions and the narrative. For example, patient moved by draw sheet in narrative, and all CERT CMS questions are listed as no. These facts conflict. Wrong signature language used. For example, patient unable to sign listed in signature type A when it should be listed in signature type B if a responsible party is available, or signature type C if no responsible party is available. Every day, the calls in the queue are reported to the Director of Clinical Education and Performance Improvement for review. The Director reviews the calls, sends them back to the crews with instruction as to what needs correction or clarification, and it's listed in the workflow comments. These comments can be viewed in the pending PCRs or inbox section of the ePCR program. The operations managers of each division are notified of the calls in their areas that need review and are instructed to make contact with the specific crew members to ensure they are aware of the return calls. Once completed, the Director of Clinical Education and Performance Improvement reviews the calls for accuracy and sends them back to billing for processing. This can be a very tedious and labor-intensive process. As you can see, it is very favorable to document accurately and clearly the first time around. Remember, the ePCR is all anyone has to refer to after the call is over. Take the time to review, correct, and review again to make sure the call is a representation of the great care that you provide. Thank you for the great work that you do every day. Hello, welcome to the Bloodborne and Airborne Pathogens course. The topics we will be discussing today are the introduction to the Bloodborne Pathogen Standard, bloodborne pathogens, preventing infections from bloodborne pathogens, and airborne pathogens. Introduction to the Bloodborne Pathogen Standard. Our objectives are to describe the purpose of the OSHA Bloodborne Standard, define who the standard protects, list examples of employees covered by the standard, describe the general goals of required bloodborne pathogens training. In 1992, the U.S. Occupational Safety and Health Administration created the standard for bloodborne pathogens to eliminate or minimize employees' exposure to human blood and other potentially infectious material, referenced as OPIM, in the workplace. So who is covered? Well, all employees who as a part of their job may reasonably be exposed to blood and OPIM that may contain pathogens. Anyone whose job involves handling or possibly being exposed to blood or blood products or OPIM. Those covered under the Good Samaritan Law are not covered under OSHA. Pathogens are germs that cause disease. Bloodborne pathogens are germs transmitted from one person to another through contact with blood or OPIM. You do not need to directly contact someone carrying a bloodborne pathogen to be at risk for exposure. Risks also come from handling clinical specimens, biohazardous trash, blood or body fluid-soaked laundry, needles or other sharps. We will provide training on how blood-borne diseases are transmitted and their symptoms, protective measures to take to prevent exposure, and procedures to be followed if exposed. And this training will occur annually. The OSHA standard requires a written exposure control plan describing how to prevent exposures through use of engineering controls and workplace practices, universal precautions, personal protective equipment. It also requires record keeping, exposure incidents reported on OSHA Forms 300 and 301, and training records to be kept for 3 years. A copy of our infection control plans and policies can be found in the Associate Handbook available on ePro. The Needle Stick Safety and Prevention Act requires employers to identify, evaluate, and implement safer medical devices, also keeping a Sharps injury log. A non-clinical hospital employee's job description now includes cleanup of laboratory space where blood samples are handled. Since these samples are contained in a sealed vial, is there any need for this employee to have blood-borne pathogens training? The answer is yes. There is a risk of exposure. Blood-borne pathogens. Our objectives in this module are to describe the stages by which infectious diseases are transmitted from one person to another. List body fluids that may contain blood-borne pathogens. For hepatitis B, hepatitis C, and HIV, we will describe how it is transmitted, its primary symptoms, whether a vaccine is available, and how to prevent infection. Also, who should be tested. Stages of infectious disease transmission include someone who has the infection, the infectious pathogen leaves the infected person's body, the infectious pathogen reaches another person and enters his or her body through blood-borne transmission, airborne transmission, vector transmission, that would be mosquitoes or ticks, direct or indirect contact. Then the second person develops the infection. The following may be encountered in your workplace: hepatitis B virus, shortened to HBV, hepatitis C virus, abbreviated as HCV, human immunodeficiency virus, shortened as HIV. This is the cause of acquired immunodeficiency syndrome, known as AIDS. In addition to blood, OPIM may include these human bodily fluids and anything contaminated with them: saliva containing blood, semen, vaginal secretions, breast milk, amniotic fluid, cerebrospinal fluid, synovial fluid, pleural fluid, peritoneal fluid, pericardial fluid, and any body fluid visibly contaminated with blood, including vomit and urine. Do exposures always cause infection? No. The risk of infection after an exposure depends on whether pathogens are present in the source blood or body fluid, the number of pathogens present, the type of injury or exposure, or how the infectious material gets into your body, and your current health and immunization status. So exposure is when you're simply exposed to a substance or pathogen. Contamination is when you're infected by the exposure. Hepatitis B is caused by HBV. Transmitted by blood and OPIM, it has been found in all body fluids. Blood and semen are the most infectious. Infections are a major cause of liver damage, cirrhosis, and liver cancer. Because of routine HBV vaccinations, infections are declining. It still infects about 60,000 people yearly. An estimated 3,000 to 5,000 people die of liver problems associated with HBV infections every year. The incubation period averages 12 weeks, with a range of 4 weeks to 6 months. Infections by HBV can cause either acute hepatitis or a chronic HBV infection. People who develop chronic HBV infections carry the virus and can be infectious to others for decades. How is it spread? By injection, needle sticks and puncture wounds, through mucous membranes and non-intact skin, through sexual activity, and from infected mother to newborn at birth. Contaminated environmental surfaces are a common mode of transmission. At room temperature, HBV may survive for several days in dried body fluids on surfaces. HBV is more easily transmitted than HIV. It can live longer outside of the body. Very little blood is needed to cause infection. HBV is not transmitted by food or water, fecal matter, the air from a sneeze or cough, casual contact such as shaking hands, hugging, kissing, or sharing a meal, utensils, or a drinking glass. About 30% have no symptoms of HBV. Symptoms usually appear gradually and are similar to flu symptoms. They may include loss of appetite, nausea, vomiting, fatigue, muscle or joint pain, mild fever, stomach pain, and occasional jaundice. How do you know if you have HBV? The only certain way to know is have a blood test. The blood test may not indicate the virus shortly after being infected. With this level of uncertainty, prevention is the best practice. The hepatitis B vaccine is the best protection against HBV. It involves no risk of developing hepatitis B. All 3 doses must be completed on the specified dates. Most common adverse reaction is soreness at the injection site. Centers for Disease Control, or the CDC, recommend vaccination for the following groups: employees at risk of exposure, people with hemophilia, those who frequently travel to or live in countries where HBV is common, those who live with someone who has HBV. The vaccine prevents hepatitis B in about 95% of people. After receiving the vaccine, you can be tested to make sure you are protected. This is important if you have a compromised immune system or your job frequently exposes you to human blood. The OSHA standard requires employers to offer the hepatitis B vaccine to employees at risk at no cost, at a convenient time and place, and during normal work hours. Employees have the right to refuse the vaccination, but then must sign a declination form. Common reasons for refusing the vaccine are: they are already receiving the vaccine, antibody testing shows immunity, and being allergic to the vaccine. You have the right to change your mind and have the vaccination at a later date. The OSHA standard requires employers to offer training and the hepatitis B vaccine before starting a work assignment. Explain to employees that vaccination is voluntary. Make certain employees receive proper medical treatment following any exposure incident. To prevent HBV infection, get the hepatitis B vaccine. Use barriers to prevent contact with any blood and OPIM. Handle sharps with extreme care and dispose of in approved sharps biohazard containers. Proper cleaning of contaminated surface is also necessary. Hepatitis C is a liver disease caused by the hepatitis C virus, or HCV for short. It lives in the blood of people with the disease and is spread via the blood. The incubation period averages 7 weeks, with a range of 3 weeks to 5 months. An estimated 3.2 million people in the U.S. have chronic HCV infection. About 26,000 new infections occur every year. Many people who carry HCV have some liver damage but do not get sick from it. Other people develop cirrhosis of the liver, resulting in eventual liver failure. In the general population, HCV is spread most often through drug injections with contaminated needles, from sharing personal items such as toothbrushes, razors contaminated with blood, from a pregnant woman to the fetus. Rarely it's transmitted through sexual contact. In healthcare, it's usually transmitted via direct contact with infectious blood through an accidental needle stick or sharps injury. Most infected people do not have symptoms. Some people feel one or more of these symptoms: fatigue, loss of appetite, nausea, anxiety, weight loss, alcohol intolerance, abdominal pain, and jaundice. How do you know if you have HCV? Blood tests can determine it. A false positive test can occur with HCV testing. Anyone who tests positive should have a follow-up test. False negative test results may also occur with HCV, usually shortly after infection when antibodies have not yet been developed. CDC recommends testing for healthcare workers who have been exposed to HCV positive blood, anyone who has used IV recreational drugs, anyone who has received a blood transfusion or organ transplant, or was on kidney dialysis prior to 1992, anyone treated with a blood product prior to 1987, and anyone with signs of liver disease. Treatment can be given to protect the liver from additional damage. HCV carriers can take preventive measures to avoid spreading HCV to others. There is no vaccine available for HCV and no cure. Preventative measures are therefore crucial. Handle needles and other sharps with caution. Use barriers to prevent contact with blood and OPIM, such as gloves or goggles. Avoid improper disposal of sharps in unapproved containers. So now we'll talk about HIV and AIDS. HIV causes AIDS. Almost 1 million HIV positive people are in the U.S. alone, 1/4 of whom are unaware of their infection. AIDS damages cells that are essential for immune function. People with AIDS are more susceptible to opportunistic infections which invade the body. The disease is eventually fatal. HIV is spread through an infected person's body fluids, including blood, semen, vaginal secretions, breast milk, and other body fluids or OPM if blood is present. Some healthcare workers are infected with HIV through work-related exposures involving blood or OPIM. Infection is most likely to occur with exposure to HIV-contaminated blood, blood products, or blood components through injection through the skin, unprotected mucous membranes, or an open skin wound. HIV is not transmitted through sharing a drinking glass, a meal or eating utensil, kissing, hugging, or touching, being around someone who sneezes or coughs, sharing a phone or bathroom, or mosquitoes, fleas, ticks, or other blood-sucking vermin. Some have no symptoms of HIV and can take many years to develop into AIDS. Symptoms may include loss of appetite, weight loss, fever, skin rashes, swollen lymph nodes, diarrhea, tiredness, night sweats, or an inability to fight off infection. How do you know if you're infected? Well, a blood test is needed to determine HIV. The result is usually positive 12 weeks after exposure. A confirmation test is recommended 6 months after an exposure. No vaccine available, and there is no cure. Therefore, prevention is crucial. Regular hand washing, use of barrier devices, and universal precautions should be used when handling any OPIM or blood. So in conclusion, all of the blood-borne pathogens mentioned have the potential to be infectious. A healthy amount of caution is needed when performing your day-to-day job functions. Complacency can lead to mistakes, and in our profession, mistakes can be fatal. Preventing infection from bloodborne pathogens. In this module, we will be discussing the following topics: engineering controls, work practice controls, personal protective equipment or PPE, universal precautions, emergency procedures for unexpected exposure, and exposure control plans. The OSHA standard requires employers to use strategies to reduce occupational exposures. These can include the following: needleless IV systems, self-sheathing needles or syringes, hand-washing facilities, sharps containers, and biohazard labels. Sharps pose a great risk to healthcare workers. Safer needleless systems are now used. Our needles have shields that help prevent accidental sticks. We review these systems annually and ensure we are using the safest products. We use approved sharps containers for disposal of these needles. All potentially infectious waste must be disposed of in a labeled red container or in red bags that are clearly marked with the universal biohazard symbol. Contaminated equipment and heavily soiled linens should be placed in these containers or bags until proper cleaning procedures are completed. Work practice controls can include using PPE, hand washing, decontaminating and sterilizing of equipment, safely handling sharps, correctly disposing of wastes, and safely handling soiled laundry. Hand washing facilities are provided and should be utilized. Waterless antiseptic hand cleanser is provided and should be used when hand washing is not possible. Hand washing guidelines include washing any skin that is exposed, ideally with antibacterial soap, immediately after an exposure. While scrubbing, be gentle with any scabs or sores. Wash all surfaces, including the backs of hands, wrists, between the fingers, and under fingernails. Wash hands immediately after removing gloves or other PPE. Antiseptic towelettes and waterless antibacterial hand cleanser can be used when soap and running water are not available. After a potential exposure, a thorough scrubbing with soap and water is still recommended as soon as possible. Cleaned and sterilized all reusable sharps, such as knives and shears, after use. Decontaminate equipment and working surfaces, bench tops, and floors with an approved disinfectant. This should happen at the end of a work shift, as surfaces become obviously contaminated, or after any spill of blood or OPIM. Be sure to disinfect jewelry and watches after hand washing. When cleaning a contaminated spill, wear proper PPE and use universal precautions. Use care when picking up sharps and broken glass, and place in proper sharps containers. Wipe up the area with a towel and place in biohazard bags. Clean the area thoroughly with a disinfectant, and when you remove your gloves, be sure to wash your hands properly. We provide sharps boxes on all of our units. No sharp shall be left on the bench seat, cabinets, or counters. Needles must not be recapped, removed, bent, sheared, or broken. The entire needle assembly must be disposed of in the sharps container. Uniforms, clothing, and cloth supplies should be kept free from contamination when possible. Clothing that becomes heavily soiled with blood or OPIM must be put in a red biohazard bag, and the operations manager should be notified to get the clothing cleaned. Laundry must be cleaned with appropriate agents and must never be taken home. In areas where blood-borne pathogens exposure may occur, do not smoke, use lip balm, hand lotion, or cosmetics, eat or drink, handle contact lenses, store food or beverages, or put pencils or pens in your mouth. Personal protective equipment, or PPE, can include gloves, yellow aprons or impermeable jumpsuits, eye shields or protective eyewear, face masks or shields, and chucks to protect from blood during venipuncture. OSHA requirements. Mid-Georgia Ambulance must provide PPE at no cost to the employee, and we must train you how to use the PPE. We must clean, repair, or replace PPE as needed. For medical exam gloves, we use either nitrile or latex. If latex allergy develops, make sure that nitrile gloves are available. Before, during, and after patient contact, check that the gloves are intact. Petroleum-based hand lotions may cause latex gloves to disintegrate. Donning and doffing gloves. Use care to not tear gloves when putting them on. When removing them, avoid touching the outside of your gloves with your bare hands. Grasp the glove at the wrist or palm and pull it away from your hand, and to pull it the rest of the way off. Hold the removed glove in your other gloved hand. Insert 2 fingers under the cuff of the glove and remove it by stretching it up and away from the hand, turning it inside out as you pull it off. Dispose of gloves in biohazard containers if heavily soiled, and wash your hands. Gowns, eye shields, and face masks protect from unpredictable splashing of blood or OPIM. All 3 can be used for heightened protection from blood-borne pathogens. Remember to dispose of all PPE properly. Handle all blood and OPM as if they are contaminated, regardless of whether or not you know the source of the substance. Remember, if it is warm, wet, or sticky and it isn't yours, don't touch it with your bare hands. Emergency procedures for exposure incident are as follows. If blood or OPIM splashes in your eyes or other mucous membranes, flush the area with running water for 20 minutes. Wash any exposed area well with antibacterial soap. Treat any scabs or sores gently when cleaning your skin. Report the exposure to management. Document the exposure in an incident report. Seek medical care as soon as possible if necessary. Our responsibilities after the exposure are that we will identify and document the person or source of the blood or OPIM. We will obtain consent to test that person's blood and arrange for testing unless the person is already known to be infectious. We will inform you of the test results. We will arrange for you to have your blood tested if you consent, and arrange for counseling and any medical care as needed. Follow-up after exposure can include treatment and medical care depending on the type of exposure. It may include a hepatitis B vaccination or hepatitis B immune globulin. The confidential exposure report form is kept in the employee's personnel file. An exposure control plan is required by OSHA. MGA's infection control plan should do the following. Identify job positions and individuals to receive training. Establish necessary engineering controls and work practice controls. Specify PPE to be used. State the opportunity for the hepatitis B vaccine, and include other measures that are job specific. Additional requirements include informing new employees about our plan. Educate new employees prior to them performing tasks that would put them at risk for exposure. Conduct refresher training annually or whenever changes are made to policies or procedures. Keep in mind work practice controls help prevent infection. Always use appropriate PPE when dealing with blood or OPIM. Keep up to date on MGA's infection control plan. Airborne pathogens. Our objectives for this module are to discuss airborne pathogens. OSHA regulations for specific employee protections are not currently mandated, but OSHA expects employers to protect employees from known hazards. There are 3 types of Airborne pathogens: viral, bacterial, and fungal. Examples of diseases transmitted are meningitis, influenza, pneumonia, tuberculosis. Many of the precautions for tuberculosis also lower the risk for other airborne pathogens. Airborne pathogens are spread by inhalation of the germ. Coughing or sneezing tiny droplets of moisture into the air containing the pathogen. Pathogens can remain airborne for several hours. The likelihood of airborne transmission depends on how contagious the infectious person is, or how virulent, where the exposure occurs, how long the exposure lasts, how healthy you are at the time of exposure, and always time, distance, and shielding. There were 14,000 U.S. cases of tuberculosis alone in 2005, caused by a specific bacteria, Mycobacterium tuberculosis. It usually affects the lungs, but can also affect the brain, spine, and kidneys. Many people with a TB infection are not sick and contagious. People who develop TB disease are contagious. About 5 to 10% of people with a TB infection develop the disease at some point. Risk is higher for people with HIV, diabetes, kidney disease, and certain cancers. TB outbreaks can rapidly expand in HIV-infected patient groups. CDC recommends HIV testing for all TB patients. So TB can be spread when a person inhales the TB pathogen present in the air after an infected person coughs or sneezes. The TB pathogen can live up to 1.5 hours outside the body depending on room size and ventilation. Infection is detectable 2 to 12 weeks after infection. Some bacteria lay dormant for years, and this can be found in latent TB infection. If the infection becomes TB disease, the symptoms may include weight loss, fever, night sweats, and weakness. If the TB affects the lungs, symptoms may include coughing, production of sputum, chest pain, and eventually coughing up blood. The tuberculin test, or Mantoux skin test, reveals whether a person is infected with TB. It's performed on the skin in the lower arm. The test spot result is checked after 2 to 3 days. A blood test, QFT-G, also reveals whether a person is infected with TB. A chest X-ray may be needed for those allergic to the tuberculin serum. How do you know if you have TB? Well, skin and blood tests cannot distinguish between TB infection and the TB disease. People found to have TB disease must be given treatment with antibiotics. Treatment can be provided by MGA if TB infection is work-related. CDC guidelines recommend a 3-tiered hierarchy of infection controls: administrative, working with public health to help prevent infections in the community; environmental controls; and respiratory protection. Environmental controls remove or inactivate M. tuberculosis. This can include exhaust fans, general ventilation, and air cleaning methods. Also, high-efficiency particulate air filtration, or HEPA, and also ultraviolet germicidal irradiation. Respiratory protection controls should be used in settings where administrative environmental controls will not prevent the inhalation of infectious droplet nuclei. Implementing a respiratory protection program, conducting annual training, and initial and periodic fit testing of N95 masks is recommended. Exposure to a known TB source should be reported to management. Employees have the right to know about exposures. After exposure, employees have the right to be tested. If infected, we will arrange for the proper treatment. We will maintain records of exposure to TB, TST or QFT-G results, and medical exams. Active TB disease must be reported to public health officials. An OSHA 300 log must be used to record work-related TB exposure and infection. A person may not be treated if there is little risk of the disease. This depends on age, overall health, lifestyle, and occupation. TB disease can be cured with a combination of antibiotics. It takes about 6 months to kill all of the bacteria. Influenza is a virus that infects the respiratory tract. It causes severe illness and life-threatening complications. It's spread through contaminated droplets that leave the infected person and come into contact with another. Sneezing, coughing can transmit the viruses. Transmission vehicles include hands, air, and contaminated objects. Viruses usually enter through the nose, eyes, and mouth. Flu symptoms include cough, runny or stuffy nose, muscle pain, stiffness, fatigue, headache, sore throat, shaking with chills, fever, dehydration, and shortness of breath. Let's discuss some prevention methods. Wash your hands for no less than 20 seconds before preparing or eating food, before and after treating a patient, before and after treating a wound, before and after using medical exam gloves, after using the bathroom, after handling garbage, after touching public items and surfaces, after blowing your nose, coughing, or sneezing, after handling an animal or animal waste, and after changing diapers. For respiratory hygiene, cover your nose and mouth with a tissue when coughing or sneezing. Cough into your elbow instead of your hand. Dispose of tissues in the nearest receptacle. Avoid touching your eyes, nose, and mouth. Wear a surgical mask when treating a patient with cold and flu symptoms. When any patient presents with cold, flu signs and symptoms, it is in the best interest of the crew to don surgical masks to reduce the intake of microscopic droplets in the air that may be spread by coughing and sneezing of the patient. The use of social distancing is important during flu season. Avoid or limit time spent in crowded settings. Avoid close, extended contact with patients with cold and flu symptoms. Stay at home if you are sick with a fever. Keep children at home if they are sick with a fever, as schools can become places where children can become easily infected by a child who has a low-grade fever and is infectious. Heed the warnings of public health and get immunized against the seasonal flu and other influenza that may have vaccines that season. Remember to take care of yourself. Stay home if you have a fever. Get plenty of rest. Drink lots of fluids. Take medicines to relieve flu symptoms. Call your doctor if fever develops or persists. Consider wearing a surgical mask when leaving the home. When taking care of others, avoid mingling personal items. Disinfect doorknobs, switches, handles, toys, and other surfaces touched around the home or workplace. If not, this could lead to secondary infection. Wash all linens that are in direct contact of the sick. Wash hands frequently. Use universal precautions when dealing with all patients. The seasonal flu occurs annually, and most people develop an immunity. A vaccine provides additional immunity, but still 36,000 people die annually. Bird flu infects wild birds and domestic poultry. It can have a higher death rate than seasonal flu. Bird and swine flu has jumped species recently to infect humans. There is concern that humans can infect one another if the virus mutates. Historically, if a pig has a disease, then it can easily jump to humans. An epidemic is an outbreak of a disease in a community or region. Pandemic is an epidemic that spreads throughout the world. The World Health Organization has determined that the world is closer to another influenza pandemic than any time in the past 50 years. Pertussis, or whooping cough, has become more of a looming threat within the past few years. Rise of infections have stemmed from the immunization scare recently. The Tdap, or tetanus diphtheria pertussis vaccine, is available at your local health department and has been recommended for all healthcare workers. In conclusion, airborne pathogens are a real threat to healthcare providers. Universal precautions, including the use of a mask, are recommended when a patient has signs and symptoms of the cold or flu. Get immunized and take precautions during flu season to avoid infection. In conclusion, know your risks in and out of the workplace. Use universal precautions and personal protective equipment and body substance isolation when dealing with patients. Get immunized. Remember to report any exposures due to the fact that infection is hard to detect until sometime later. Remember, use a healthy dose of caution and the proper amount of personal protective equipment so everyone goes home safe at the end of the shift. Thank you.